accomplished, and a lot is yet to happen. Throughout the meeting, all attendees will be asked to participate through polls and voting and use of the chat box. It is through your membership that our society grows stronger and more effective in our advocacy for people living with disabilities. I personally want to say a big thank you to each and every CDSH member, and I salute your valued support and your ongoing energy. The business portion has bylaw changes, a board to ratify, and several concise yet exciting reports. Really, it's boring, but we'll get through it efficiently. The required information, bylaws, and board candidates has been forwarded to everyone about 2 weeks ago, and this is to keep you current and ready for ratification. The absolute highlight today will be our keynote speaker from France, who will be introduced to you very soon. And now I'd like to have a moment of reflection. As we gather today, we are grateful for this meeting and for the warmth of each other's company. At this time of global turmoil, let us take a moment to reflect on the importance of world peace. Let us be reminded of the values that our organization stands for: ethics, compassion, understanding, and caring, and the role that we all play as members in promoting such values through our work and education. We offer our thoughts and prayers for those around the globe who yearn for peace. And this is whether in their lands, in their communities, or in their hearts. We look forward to sharing in today's important meeting in each other's camaraderie. Let both give us strength to play a part in building a more peaceful and loving world for all, as individuals and together with our advocacy as members of the CSDH. And now I'd like to continue with our land acknowledgement. And I am speaking with you from London, Ontario. This land acknowledgement, by extension, applies to all other Canadian geographical territories and the First Nations that reside in them. London is situated on the traditional lands of the Anishinaabe, the Haudenosaunee, the Lenape'wak, and the Attawandaron nations. We honor and respect the history, languages, and culture of the diverse Indigenous people who call this territory home. We are grateful to have the opportunity to work and live in this territory. Thank you. And now I'd like to hand off to Dr. Olaf Plotsky, our immediate past president. Olaf?
Thank you, Paul. Make sure I'm not muted. It's my distinct pleasure to introduce the 2023 CSDH board members. As you can see them on the screen, besides Paul, Clive, Carol, Joan, Elizabeth, Shauna, Sharat, Sherry, and Steve. I had the pleasure of working with these incredible individuals. We've identified the fact that Clive Friedman and Sherry McKinstry have stepped down for the board, and this makes room for Ms. Lara Timler, who is a professor of hygiene at Fanshawe College here in London, and Dr. Lindsay James, who is a pediatric staff at Dalhousie University School of Dentistry and at IWK in Halifax, and is currently leading a project for an operating room they're developing for adults and children with special needs. I think that's it. Okay, Paul, it's back to you.
No, one more, Olaf.
One more? Oh, thank you, Barbara. My role at this point is to acknowledge that Dr. Denise Faulks has joined us today for her keynote speech, and Dr. Clive Friedman will give you more information as to Denise's background and current work that she's doing in France.
Thank you. And I would just like to mention again that we have sent the 19th of November 2022 minutes from our previous AGM to everybody, and we have heard no changes from anyone. So at this point, I'd like to have someone call the motion. Do I have someone to calling the motion?
I would like to move that minutes.
Thank you. Joan, and second?
I'll second.
Thank you, Steve. All right,
And the
now
poll,
you have a poll up and you can vote for all in favor. Thank you. Just let me know when that poll closes, please.
just want to make sure everybody can see the poll and you can vote, correct?
We should be good. 20 of 20 have responded.
Oh, okay, you see that, I don't see it.
Okay, yeah.
And we have a majority.
Yes.
Thank you. Then we'll move on to the agenda review for today.
Thank you.
And indeed, everybody has had this circulated and there has been no additions or comments forwarded. So I would ask for someone to move this motion, please.
Hang on one second, sorry, Paul.
The agenda. Pardon?
We got, let's see, oh, this is share results.
I'll second.
Thank you very much for seconding. And
Here we go, sorry, there we go, okay, launch.
then we'd have a vote for the agenda, please.
I don't see the poll.
Okay, Barbara, can you see the launch?
No, I don't have the polls up here anymore. Only you do.
Okay, let's try this one more time, my apologies.
Yeah, you were still showing the minutes of the previous meeting.
There we
There
are.
it is. No, that's minutes.
That's the results from, that's the results from last year's.
Okay, so can you close that? Because on my screen, I'm seeing the agenda and I apologize.
Maybe we could just do a quick show of hands on that one.
Quick show of hands, please, and thank you.
Okay, apologies for everyone.
I do believe that has passed favorably. Thank you very much, everyone. And now I'd like to hand off to Clive Friedman and to introduce our guest speaker. Clive, please.
Well, it gives me great pleasure to introduce to you Dr. Denise Faulks from Clermont-Ferrand, France. I have known Denise for quite a long time now. And I cannot think of anyone better than Denise to do a presentation for us. Denise has been involved in research and special care for many years in Clermont-Ferrand. She has instigated a lot of the work related to ICF, the International Classification of Health, in terms of attitudes, in terms of case complexity. Denise's research is stunning and probably has a CV of papers with respect to special care that goes beyond most individuals I know across the globe. So Denise, without further ado, I would like to welcome you to this gathering and really look forward to your presentation. So thank you so much for joining us.
Thank you, Clive. Thank you to the whole board, to Paul, to Olaf, to Barbara, those I've been in touch with, Sharon, of course. So thank you for this very important invitation. So I hope that you, I hope that I will be up to scratch. So my remit today was to talk about case complexity and how we've managed to use that in France and how we've managed to push the agenda forward. Clive has very kindly introduced me. I'm a clinician at the University Hospital in Clermont-Ferrand, and I work majoritarily with adults with disability and multiple pathologies. But as he said, I have various other hats as well. So I'm on the executive of the French Dental Disability Association, and I'm chair of the International Association for Disability and Oral Health. So care complexity. I'm going to have to ask Barbara each time to change slides. Sorry. So if there's going to be a slightly less fluid. But the main thing that's important to me in looking at complexity is why we do it. Why is it so important to identify our patients? And I think that the Lancet series that was hugely influential in public health that came out in 2019 was really very, very clear about the problems faced by our patients. So they stated that extreme oral health inequalities exist for the most marginalized and socially excluded groups in societies, such as homeless people, prisoners, those with long-term disabilities, long-term illness, refugees, indigenous groups. And all of this serves to illustrate what's a classic example of the cliff edge of inequality. So we can really situate our patients on that cliff edge. We know that there is massive need, and it really is a global public health scandal almost that our patients do not get the care that they require. So can we move the slide? Thank you. So in many countries around the world, people are faced with these challenges. Structures, policies are evolving to try and explicitly provide services for persons with special care dentistry, with need for special care dentistry. But one of the main problems encountered by policymakers has been the identification of populations. We know that these patients are underserved in healthcare. We know that they are ill-defined in terms of administrative health rights. Certainly in France, it's very difficult for policymakers to perceive the difference between dependent elderly patients, patients with disability, children, and all of these groups will have different regulations and different administrative rights. We also know that our population is excluded from standard epidemiological surveys. We know that when we're doing surveys, when we're counting caries, when we're looking at populations, we don't go into residential care, we don't go into institutions, we don't go into hospitals. We do not go as far as trying to collect data from people with communication problems, people with behavior problems. So our population is hugely underrepresented in terms of data collection. So in order to improve access to care for persons requiring special care dentistry, we need to help policymakers to be able to target those populations, and particularly those populations that require positive discrimination within oral health care. So when we're talking about positive discrimination, we're talking really about the difference between equality and equity. So it's those populations that need a little bit more to achieve the same health outcome as their peers. Thank you. So what would we use these tools for? If we had a magic tool that could really identify clearly the populations requiring special care dentistry, we could then use that for epidemiological data collection so that we have high quality data, that we know who we're talking about, we know what the needs are. We could then use that to justify allocation of resources, whether in terms of commissioning services or whether in terms of financial compensation or whether in terms of human resources, getting enough personnel on board. We would be able to find service requirements and workforce deployment. We would be able to improve the identification of populations and of certain needs within that population for research into adapted solutions and to make sure that those solutions provided equitable health outcomes for our patients. We would be able to secure and optimize care pathways, so how those patients move between primary, secondary, tertiary care when we refer. And then we'd also be able to improve triage and referral of persons seeking care, even down to the dental school. We decide whether a patient is appropriate for an undergraduate clinic or a postgraduate clinic or for a specialist clinic. So this could be something, these sorts of tools could really be used widely within our special care profession. So how do we go about it? There are definitions of patient complexity. I think this is probably one of the best. Peak defined complexity is interference with standard care and decision making. So it's something to do with what we would be doing normally with other patients that we have to do a bit differently with our patient base. So interference with standard care and decision making because of symptom severity or impairment, because of diagnostic uncertainty, when we're not really sure what's going on, when we can't get the communication, when we can't get the description of what's going on, the difficulty that these people have in engaging with care, the lack of a social safety or participation, disorganization of care, and the difficulty in creating strong patient-clinician relationships in these populations. So there's a whole load of things going on in there. There's things to do with the patient and the patient's condition. There's things to do with the social structure and the social context. But it's really very, very clear in the literature that there's a consensus now that trying to identify subgroups of persons simply by medical diagnosis is totally inappropriate, because complexity is both individual and multifactorial. So the days have gone where we could say all people with Down syndrome require special care dentistry. No, that's not true. That some persons with Down syndrome will be able to accept care very straightforwardly, and others will need to go to GA, will need a lot of adaptation to care. So how do we define, if we start with a definition, this is the International Association definition. I know that in Canada, you probably use the term special healthcare needs more than you would use special care dentistry. But I think basically we're talking about the same thing. Within the IADH definition, we're looking at individuals that have an activity restriction, a health condition, or a disability. And these restrictions or conditions or disabilities have to directly or indirectly affect the oral health of that person within their environmental, within their social context, and within their personal context. So this picture is a moving picture. People will not need special care dentistry perhaps throughout their life course. They'll need it at specific times or in specific situations. The population for the IADH at least includes patients of all ages, patients with disability, people that are medically compromised, people that have mental health issues, people with dental fear, frail older persons, prison populations, refugees, homeless persons, amongst others. And if we think back to the cliff edge of oral health inequality, all of these groups are included within that. So this definition goes back to the International Classification of Functioning and the WHO document that relates health directly to human functioning, to human ability, and therefore human disability, and to social context. So we have to have a holistic view of our patients if we're trying to work out exactly what makes things difficult for them to access care. So many countries have gone down the line of trying to develop a case complexity tool or a case mix tool. The first to be developed was in the UK. So it was the British Dental Association special care case mix model that came out in 2010. And that's been adapted, modified, validated in certain situations. And the latest version came out in 2019. I learned, unfortunately, fairly recently that you have your own Canadian complexity assessment form that, if I am right, came out in 2021. Happy to be corrected on that. But there's a lot of countries now going down that line. So recently we did a scoping review to try and find out what was out there in terms of complexity tools. Unfortunately, the Canadian tool wasn't on PubMed, so it's not been included in the scoping review, but we were able to identify 10 tools. And these either predicted the complexity of dental management, so something to do with prospective anticipation, or how do we think this is going to go forward, or retrospectively judge the complexity of care. And I think that as we go through, I think it's quite important to try and find the difference between those two perspectives. Are we thinking about what's going to happen in the future, or are we thinking about what's actually happened today? So the implementation, sorry, we've just skipped a slide there. Yeah. The implementation of the tools has varied according to national context and health service structure. But so far, the tools in the literature have been used to justify allocation of resources. So as basically a commissioning tool in the United Kingdom. Commissioning in the UK implies negotiating with the local health service for services for the coming year to say, okay, this is how many patients with disability are going to be treated in this particular clinic over the next year, and trying to negotiate that up in advance. In France, we're using it for direct financial compensation. In other countries, it's been used to define service requirements. There's a version of the BDA tool that's used in Malaysia to try and justify human resources within special care. And it's also been used to optimize treatment planning and care pathways. For example, the Australian version of the British tool is used for triage and for referring patients. What is interesting is that none of these tools specifically take into account the complexity or the technical aspect of the dental treatment to be performed. And yet, thinking about this, we know that that is actually one of the major factors in oral health inequalities, or certainly in oral health outcomes. When things get difficult, when things get complicated, when things get out of hand, professionals do prefer, consciously or unconsciously, to propose simpler treatment options. So we have in our populations, we know there are more extractions than in a general population. There's less complex care, there's less endodontic treatment, less fixed prosthetic treatment. So there is something to do with access to care and problems with the technical nature of dentistry. So it's a thought that we've been discussing with the IADH, is that the nature of the planned dental treatment should perhaps also be included in future case mix tools, particularly if they're to be used prospectively. If they're used retrospectively, it's in there anyway, because it's what's just happened. But if we're thinking about where we're going to go, who should this patient be referred to? If there's not a high dental need, if it's simply a question of periodontal maintenance, then perhaps they don't need to see a specialist. Whereas if they need a full oral rehab, then they very well might need a specialist. So I think that's another aspect that needs to be taken into account in the future. This is just to go back to the Canadian tool, which wasn't in the scoping review, but the Canadian version specifically states that it aims to assist in decision-making regarding referrals. So this is something you may want to take into account. So it's looking really at this what you've called the spectrum of need and disability, looking at the role of primary dental services and how patients then can move between routine care, moderate adaptation, and complex specialist care. So in the battery of case mixes, the IADH is currently developing a universal case mix tool. We're using an international Delphi consensus process to do that. And the first results of this process will be presented in Korea. So those of you that are unaware that IADH will be held in Korea in next September, then you're very welcome to join us there and hear more about it. What is the challenge with trying to build a universal case mix tool is that we know that there will be a certain amount of adaptation necessary in terms of local culture, in terms of local terminology, and in terms of how the health system works. And adaptation will also be required depending on how the tool is intended to be used, whether we're looking at health services, systems, or policy levels in different countries. So, okay, what happened with us in France? What happened with us in France was that at one point that we'd been pushing, obviously, for change and for financial aid and all the things that I'm sure you guys are pushing for a number of years. And suddenly in 2018, somebody in the health ministry woke up and said, hey, okay, this is where we're going to do it. They were changing the rules for dental payment and the fees for different types of dental care. And the policymakers decided that they wanted to introduce compensatory measures for dental practitioners treating patients with disability, which is great news. I mean, you know, then you've got to be able to reply straight off and be ready with a tool. So the plan was to give a financial supplement over and above the fee per item fee, payable directly to dentists in recognition of the additional time and expertise required to provide special care dentistry. And I know that our context is very different to the context in Canada. Basically, dental care in France is all provided within the public health service. So it is a very different system. But within that, of course, the desire to increase access to dental treatment was tempered by the desire from policymakers to ration the financial compensation and control costs so it didn't get totally out of hand. So this deadlock was broken because the French Association had already been working on a case mix, mostly to try and bring attention to our population groups. So we'd already been working on a tool that was designed, in fact, to be a checklist of domains of adaptation to standard care. So we were able to propose that to the government and say, okay, if you need something that justifies this financial compensation, then perhaps we have the solution for you. So this is where the case mix was then brought in terms of justification for the financial compensation. What was interesting was that that wasn't enough for them. A tool that identified adaptation to care wasn't sufficient because they were scared that other people that were not disabled might get on the bandwagon. So all of our patients that we would still consider needing special care, so those patients that are incarcerated, those patients that are refugees, or with that the social side of special care dentistry, they were not wanting to recognize. So in addition, the National Health Service added that the patient must have severe disability for eligibility and must score on the French case mix. So what does the case mix do? What does it ask? The French case mix have 7 domains, so each implying, as I said, adaptation to standard, whatever standard care is on the part of the dentist. And it's a 4-level score, so there's either no adaptation, minor, moderate, or major adaptation. And we'll go through the 7 domains. So the case mix tool is a little bit different to the British tool because it's completed retrospectively for each treatment session. Okay, because we're looking at whether that session has been difficult enough to justify financial compensation. What will happen is that for a practitioner, they will welcome their patient, they will undertake treatment as they would have done normally. And at the end of that session, they'll think, okay, that was complex, that was difficult, and then score how they got on that day. And the idea behind that is that not every patient will need at every session to be recognized as complex. We have some very complex patients that come in, but if all you're doing is a quick exam, you may not need that time and expertise that's extra. If you're going to do endodontic treatment, then it becomes a different kettle of fish, and the financial compensation is justified. So the tool is completed retrospectively for each treatment session, not per patient, but per session. So following a patient encounter, if the treatment session scores moderate or major adaptation in any one of the 7 domains, the dentist is eligible for financial compensation, which means that it was really important that these 7 domains be independent. And if any of you are aware of the British tool, this is also a major difference, because the British tool has a summated score, a weighted score, which I think is actually a major disadvantage, because if somebody scores very highly on a communication problem but has no other real problems, they may not score high enough to register on the case mix. So what does it look like? It's basically a checklist. And this checklist is now part of the public health system. It's part of the dental health payment system, and it's integrated into the dental software packages. So everybody now has this in France integrated into their dental payment system. So what are the domains? The first domain is communication. And the examples I've given you here are only the examples for moderate and major adaptation, but a patient who scores a moderate or major adaptation in any one domain, if you remember, is then eligible for financial compensation. So moderate adaptation in terms of communication will be things like communication via a third person, moderate learning difficulties, deaf, blind patients, and then major adaptation would be when there's no real verbal communication, where there may be severe learning difficulties, severe dementia, where any kind of relationship with the patient is going to be difficult to put in place. So the second domain is to do with the need for sedation or general anesthesia. So in moderate adaptation, as soon as we get into conscious sedation, hypnosis, nitrous oxide sedation, that will trigger kind of compensation. A major adaptation is when we need to get involved. We need to get an anaesthetist, an anesthesiologist on board, because we're looking at general anesthesia or deep sedation. We're also looking at patient behavior or patient cooperation. And for this, we use the modified Venom scale, which we actually use very regularly anyway. It's a really good tool to help you keep track of how your patient reacts during treatment. It can actually be scored at various times during your treatment session. So how they are in the waiting room, how they are as they come into the surgery, how they are during treatment, how they are after. So if you don't know the Venom scale, it's worth looking at. But in terms of the case mix, moderate adaptation would be things like hands coming up, getting in the way, a very difficult examination, verbal opposition, patient's obviously extremely reticent. A major adaptation is when it all goes wrong and the patient gets very upset, is no longer in contact with the dentist with any kind of verbal contact. The treatment's regularly interrupted, and then we're looking at escape behavior, clinical holding. So the bad end of the scale where we don't want to go. We also look at, so the fourth domain is medical health. And what was imposed by the French ministry was the American Society of Anesthesiologists classification, which is actually not very easy for us in terms of dental care. But basically the patient will trigger compensation if there's at least one moderate or severe systemic disease that's not stabilized, or major is a constant threat to life. So that's the same ASA scale that you already used, I would imagine. The next domain looks at dental risk. So we're looking at dental risk in 2 ways. So dental risk is risk of dental disease. And the risk of dental disease can be related to a syndrome, to a dysmorphology, to a disease, to a pathology. So, for example, it can be to do with dysphagia or cleft lip and palate, trismus, uncontrolled movements, peg feeding. So all of those risks would be a moderate adaptation. And it's a major adaptation if that same patient also has poor oral hygiene or poor dietary control. So we're upping the stakes in terms of risk of dental pathology. So the next domain is autonomy. So autonomy is to do with how independent the patient is in terms of accessing care. A moderate adaptation would be that there has to be the carer with them during treatment in order to help with communication, to help with behavior support, to help for transferring the patient. And major adaptation would be that same patient coming in, patients coming in from a psychiatric unit with 2 or 3 carers, needs to be carried for transfers, or continuity of care is regularly interrupted because they're in hospital, they're in and out of care. So it's that kind of independence in accessing care. And then the last domain is to do with the administrative coordination, because we all spend hours on the phone and writing letters and trying to get replies. And that is reflected in the time that's needed for patients that can't deal with their own administrative burden. So moderate adaptation is to do with the administrative burden borne by the dentist in one sector, whether that's medical, so getting hold of the cardiologist, getting hold of the general practitioner, trying to find out what's going on medically, or medico-socially. So it can be talking to the social worker, talking to the residential home, getting feedback from them, or it can be medico-legal. So all issues to do with trying to find somebody that will help with the consent process for patients that have problems with consent. And then major adaptation will be about that burden borne for several sectors. So you're really coordinating between all the different sectors, and you're the one that has to do that, the time and the energy that takes. So those are the main domains in the French tool. Just to compare very rapidly with what your system has, so the Canadian complexity tool has 5 domains that it's always recut. Yeah, so we're looking at communication, care resistant behavior, medical history, dental history, treatment needs, and the personal and environmental barriers of access to care. So we're basically on the same wavelength, and all of these tools do bring up pretty much the same domains. So how did we go about dealing with the French tool? Obviously, once it goes into the public health system, it has to be checked for validity. I mean, we had to look for its psychometric properties. So we looked at the content validity. So the first round of testing was 392 patient encounters with professional experts, and looking at how that worked and changes following that first round. We designed 12 fictional patient treatment episodes that were tested by 51 dentists. So they scored those patient episodes once, and then they scored them again 2 weeks later to look at the reproducibility and other factors. And then we went really into the field, and we managed to collect over 1,800 treatment episodes nationally to look at reliability and other factors. So what we found is that our tool does have good content validity. We know that we have good internal consistency, that the floor and ceiling effects are reasonable, that we have good construct validity, criterion validity. We have interdentist reproducibility, so 2 different dentists will score pretty much equivalently. And we also have intra-dentist reproducibility. So if the same person scores the same patient a couple of weeks later, they will still score the same level. We know that the items are interpretable, and we know that the scale is reliable. So that was all good news. We've got high validity, good psychometric properties. But what was even more important in this context was that the 7 domains were shown to be independent, which justifies this dichotomous response outcome. Yes, the adaptation necessary for care for that patient was sufficient to warrant financial compensation or not. So our tool's a little bit unique because it's the only one, as far as we're aware, that's used specifically to justify financial compensation to dentists. So it is written into the public fee scale, and it appears in all the payment software. And as far as we're aware, no other case mix has been used directly for this purpose. I know in the UK they've tested it, but because the domains are not independent, it's something that's quite complicated for them. I think it's the only one that has a real cutoff, so a demarcation between those that are deemed to be required adaptation for dental care or not. One thing that was interesting, though, in the validation studies was that you go through all this, you fill out this tool, but in fact, we shouldn't need to justify. One of the major findings was that the reply simply to the question of, do you think this patient requires complex care or special care dentistry, was highly correlated with the results of the case mix. So it would probably be cheaper and easier for the health system simply to ask the dentist whether they think that the patient requires special care, and to trust them to know that. But trust is a difficult thing, is it not, to put in place? So impact in real terms, impact in access to care. In terms of health economics, this has not been fully investigated yet, partly because we're having real trouble getting the figures off of the National Health Service. We know that the new measure has clearly made an absolutely huge difference to the financial stability of pre-existing special care services. So people already providing these services suddenly found themselves in a stable position financially, whereas beforehand they were running around looking for money, trying to get extra money off the region and trying to find other resources. So that has made a huge difference. However, the impact on increasing access to care in general dental practice, or even in the creation of new services, is unknown. So we don't know. I mean, that was the idea. That was the government's idea, was to say, oh, if we pay the dentists to do it, then they will do it. As you know, it's not quite as simple as that. So anecdotal evidence and the limited data that we have managed to recover would seem to show that the measure at the moment is little known. So not enough dentists are aware of it, and it's also still little used. So we've still got a long way to go in terms of making real change. Although the fact that pre-existing services are stable financially is huge, but we're not perhaps increased access to care yet. So what did we say from the beginning? We said that we wanted this tool to do a lot of other things than just provide money to dentists. So this is something that we will and are using the French case mix tool for, is to further into epidemiological data collection, looking at defining service requirements, improving identification of populations for research. This tool does provide all these other things with it. Even though it's only been put in place for a financial measure, the data is there. If we can get our hands on it, the data is now there, which is really, really important. And I'm, as you can tell, dying to get my hands on that. I will manage soon. And all of that, obviously, with the ultimate aim of reducing this cliff edge. I mean, this is just totally unacceptable that our patient base is still hanging on the edge of massive oral health inequality. And so if we go back to lessons learned, yeah, that's fine. You can change. Thanks, Barbara. Of looking at changing policy. I was earwigging and listening into your conversation, Paul, at the beginning, and Olaf said that you've got a meeting coming up with the ministry, but that is so important. We had a conversation with Clive this summer when we met at the Nordic Association, where he seemed to be saying, oh, there's some things you can't change. There are not some things you can't change. There are things that can be changed if we decide that that's what we're going to do. And I think the thing is to be really, really obtuse and decide that this is where we're going to go. So changing policy is possible. It takes a lot of preparation. The example I've just given you of the French system, we've been building coalitions for a long time. And I think that coalition building is really, really important, but it has to be a coalition between patient groups. Get your patient associations on board, between the medical social groups. So get the residential care, who organizes that residential care, who is aware of the problems on the ground, who can advocate for these patients that are not health professionals. You also have to have knowledge of policy, what's going on. So what are the opportunities? When is the dental fee due for renewal? When is the next big governmental meeting around access to care for disability? You have to know what's going on. You have to know what the agenda is doing. But then you have to be ready, because when that opportunity comes up, you've got to be able to step in with something that's pre-prepared, because it's usually you got like a 10-day window to reply to these things. So then you get opportunities to help develop policy, to advocate for policy. And like I say, when we go into the ministry, we will always go in or try to go in as a tripod. So patient representative, a dental representative, and a medical social representative, so that we're covering all those areas. Because what you tend to find is if you go in as a dentist, they're saying, oh yeah, they just want more money, more resources. They're always asking for the same thing. But if you've got a patient that goes in explaining what it's really like to try and find dental care, then you tend to have catch the attention of your political leaders more efficiently. So originally on this slide, it was advocating for equitable outcomes for those most disadvantaged. And I feel very strongly that it's with those most disadvantaged. We can't talk for them, we have to talk together. And then if you manage to get a foot in the door, then you can help out with implementation. So don't give up on making real change. It can happen. It takes a bit of luck. It takes the right opportunities at the right time. You have to be prepared, but that you can push things forward. So that was my optimistic conclusion.
Thank you, Denise.
And just on the last slide, sorry, Sharat, before you, just don't forget, guys, that IAGH 2024 is in Seoul, and we'll be talking more about case mixes there, that's for sure.
Thank you very much, Denise. Yes, it was always a pleasure. It's always a pleasure to hear you speak. And before I go into my formal role of thanking you, there are some questions, some of them sent privately on chat and some of them, of course, on the public domain. So the first question that was sent privately and kind of ties into what Olaf has raised as well is when you validated this toolkit, did the people have to be taught how to use it? So, like were general practitioners trained in the use of the toolkit, or was it just something that was sent out to a GP as is, and were they able to pick it up?
The tool was imposed by the National Health System from one day to the next, bang.
Right.
So people were not trained. Having said that, frankly, it's not difficult. It really is just a seven domain checklist. So when we looked at how long it was taking for people to fill in, somebody that had already filled it in a few times was taking a minute to fill it in. Somebody who had to read each item was taking up to 5 minutes. But it's not a complex tool to use. It's dead easy.
Right, and that brings us to the next part. Actually, I know, Jones, it's a large question, so I think I'll break it up for the sake of discussion into two parts, so that I think everyone can get a sense of what this is about. The first part is actually, I believe the question says that has it actually improved access to treatment under hospitals or under GA in hospital, or GA clinics, or is it basically primarily access to community clinics that has improved? So.
So the way that things work in France is that dental care is provided, basically 90% of dental care is provided in general practice, in town, on the high street, in small clinics. There's no community dental service. There's a very small hospital service, which has been helped by the measure because it's brought in, because the hospitals were providing services, but usually at a loss. And now that has been overturned. So it's certainly helped. Like I said, what I don't know yet is whether new access has been opened or new general practitioners that didn't used to provide care for these patients have suddenly thought, hey, yeah, maybe I could try this now. That's something we don't know yet. But hopefully we should get our heads around soon.
Right, and this is the second part of the question is actually something that I'm actually interested in here as well, because the province I'm in right now in BC, that's the way it works. Kind of the role of the medical practitioner, because what role does the medical practitioner is the medical GP able to say, oh, listen, this patient needs to be seen in a hospital, or do they have any say in that at all?
No. A patient. So like I said, the majority of treatment is in ordinary general practice. So you may have patients with what the British would call a special interest, that have done a bit of training, that are more interested in this population, that are part of a network that takes on these patients, or they may end up in hospital care. The way that our service works, one of the very few specialist reference center, is that the patient has to be referred. So they will be referred either by a medical practitioner or by a dental practitioner. So they can be referred by either. But at the moment, the French case mix is not being used as a referral tool. It's starting to be by dental practitioners that now know, so they can justify their request for referral by saying, look, this is the score on the case mix. But medical practitioners are not aware of this yet.
Okay, and actually I've just received another follow-up on that, which basically asks if you could just go into the role of the ASA classification. Does that play a role in who comes into the hospital, or is it just basically let the GP do what the GP is comfortable doing, follow a functional model rather than a medical model?
Yeah, no, it's a functional model.
Right. So we don't actually say, okay, you've got such and such a condition and you're coming to the hospital because of.
No, because you can have a very complex health condition, but only need a checkup.
Right.
So the idea is really to evaluate what's going on in that treatment session, which is how the degree of dental complexity, the actual degree of technical complexity comes into the question, even though it's not an item. Because it's obviously the session will go more easily if what you've got to do is easy.
Right.
If you're trying to provide complex care for a complex patient, then it's obviously going to score higher.
So we have about 10 minutes, and I'm just going to get to Shona in a bit. There's just one more comment by Liz that I just want to frame as a question to get your opinion on this. So in terms of retrospective versus prospective, have hospitals in France started to do retrospective audits of the kind of patients they were seeing to see where they fit on the tool? Or is this something that's just been done in the UK? Because I think that was it was something that has been asked, and I just want to frame it as a question.
Yeah.
So yeah, what are your thoughts on retrospective versus proactive? So.
But specifically in hospital, was that the question?
Well, I'm just paraphrasing here. I think the thing was basically to bring up the role of the tool as a proactive measure versus the retrospective measure. But in general, my addition to that as a question was, do you see people doing retrospective audits of the cases they've seen as a research method, or do you see this happening, or do you see this more as a proactive measure? In terms of
No, there's So in terms of the use of this data is being collected. This data is being collected by definition, because if you want the money, it has to go into the system. Yeah. So once the data set is there, we have every incentive to go and look and see what's going on. Who are the patients? Where are the problems? What is going on with these patients? Who treated them? And that data is held by the National Health Service. So we've been managing to get hold of it bit by bit. And our next big push is to try and get that whole data set so that we can really go back and look nationally at what's happening. In terms of local teams, or in terms of local clinics, or a hospital, we certainly look at all our data. We make sure that we know what's going on. But this has only been in place really since 2020. So we've not got a huge time gap to look back on.
And just also raise Liz's question on, is it being used as a proactive functional assessment tool prior to treatment?
No, but by definition, it's filled in after a treatment session.
Right.
Because it was designed to take into account the complexity of the dental
Okay.
ACT, the dental treatment that we were
It makes
using.
sense. I've got Shauna's hand up for a long time, so I'm just going to give Shauna 5 minutes. I'll get back to another question regarding the same hospital and GP, because we face a rather different challenge in Canada where you have to get a referral into the hospital system.
Okay.
So I'm just I'll come back to that if we have time, but I know that Shauna's been waiting for a long time. So Shauna, go right ahead.
Thank you, Dr. Fox, for your fantastic presentation. My question is about your psychometrics. Do you have any data that compares the various subgroups? For example, how this tool functions for, say, the dementia population versus the intellectual disabled population?
No, that's easy. No, not yet. But we will have once we get hold of the whole data set, because the original validation study was on, like I said, over 1,800 patient encounters that were sent back to us from special care dentists from around the country, so nationally. But now that the data set has, this has been several, a couple of years down the line now, that data exists. So we should be able to get access to that eventually once we persuade the ministry to hand it over.
Thank you.
Great. And in the interest of fairness, I just wanted to open up to anything else before I go back to Joan's question of hospitals, because I know that this is something that is passionate to a lot of people on this panel as to who gets to work in a hospital and how on hospital privileges. But I just want to bring this up. I think there's another question out here. This is basically from Shelley, who asks, so when a dentist is reporting the results of the case mix, are all the answers submitted and is the patient's condition listed?
No. So the case mix goes as it is. I mean, it's obviously related to the patient's notes, which are also in a national system. But it is willingly disconnected from medical diagnosis. The idea was not to go back to that medical model. The idea was to say, okay, this session was difficult. These are the reasons why.
Right. Okay, so I have Carol and then I have Steve. So Carol, go right ahead first, please. So.
I'm glad you guys are asking questions. That's interesting.
You've got a highly engaged group. Thank you so much for your amazing presentation. It's so interesting, and definitely, for Canada, we're on this journey. I liked your slide about never give up. Anyway, my question is around oral health professionals in your country. Are they using any type of universal pre-assessment, like functional assessment, pre-visit questionnaire, or tool that helps them kind of identify what potentially they need for time, or a quieter room, or first morning appointment, all of that?
Yeah. So in France, no, there's no standardized tool. And we certainly, I think most people that really specialize in this sorts of populations have their own sort of pro forma that they send out, or information that they will collect pre first appointment. I think that's really, really helpful. That's the worst thing that can happen, is have a patient turn up where you have no information about whatsoever, so you don't even know how to welcome them properly. So I think that is your question is really important. I think I'm not 100% sure, but I think that the British Association has a document on that, and I'm pretty sure that the Australian Association does too. So there may be more universal tools out there to get a pre-appointment, at least a basic pre-appointment information form.
Well, that's great. Yeah, what I'm thinking, like we developed just a questionnaire. We're launching, and some colleagues and I, and after we made the questionnaire, we realized it's for everyone. It isn't really just for people with a known disability, and so that's why I really was keen. Like, This could be a universal thing.
Yeah, but the tool, the French case mix tool, as it was designed, I mean, it was designed before this whole political thing came up, was designed simply to measure need for adaptation, and it was not designed for special care patients directly. I mean, it could be used for any patients. You know, there's a lot of patients that are not identified, labeled, that still have need for adaptation quite clearly.
Thank you.
And Steve, I think that would be the last. I don't think there's any more on chat, so I give the floor to Steve.
I've had enough.
Good, thank you. Thank you, Dr. Faulks. An incredible lecture. Very, very informative. I really enjoyed listening to you. I have more of a comment than a question. I treat patients in hospital under general anesthetic, and I like the note that you made near the end of your presentation, where just ask the dentist, because I typically, the patients that are referred to me, they've been to 3 dentists already who couldn't treat them, and then they end up in my lab. So I think that's a huge thing and very inexpensive, and you know, it involves trust, though. It involves trust, government's trusting the dentist. And I also like the fact that your case complexity tool is used for data collection, you know, retrospectively and going forward now, and then you could, you know, see and measure uptake and of dental services, and if the those who improve their access to care for dental services, not just in office and, you know, on the street in private practice, but also in hospital too. So thank you again. It's excellent presentation.
Thank you very much. Just to add to that, it's actually very ironic, this whole thing about asking dentists to justify whether the patient requires special care or not, because there's a similar measure in France for general medical practitioners. So they can ask for a special fee for patients with disability or with complex health condition. So they get like a double fee for a complex consultation, but nobody asks the medics to justify which patients are complex or not. So yeah, this is the reputation our profession has, and this is why it's important to use patient advocates when you're trying to negotiate, because I think that the relationship that our profession has with the health ministry is not necessarily the one we would wish.
I guess it's historic, you know, if you go back to the Americans, Painless Parker, who used to march into a small town, you know, with a band and, you know, dancing girls to perform dental treatment, the kitty corner to the saloon. You know, I wish that would change. It would be great if there was trust.
But it's up to us to make that change, to prove that we're trustworthy. Yes. I mean, we shouldn't have to, but if we do have to, let's go that way. It doesn't, you know, let's just do it. If it needs doing, do it.
Exactly. Yeah. Great listening to you. Thanks.
Thank you.
And Joan sends a sincere thanks. Joan, I hope I raised all your questions. Was there anything that you'd like to add that I may have missed?
My only question really was whether the doctors the French dentists are able to themselves admit, do they typically have privileges at the hospital nearby, recognizing these are smaller hospitals you mentioned, but do your GP dentists typically have privileges? So
I don't think they'd call it privileges. I think they'd call it something a lot more negative. No, they typically not, but increasingly yes. So there now are quite a lot of examples of general dental practitioners gaining access to operative care within hospital, to GA services. So that is becoming more frequent. I wouldn't say it was widespread, but it's certainly becoming a lot more frequent than it used to be. And the problem with GA services for general practitioners up to now has been the usual, I don't know if it's the usual problem with you guys, but oral surgeons, so that the people, there's not many specialties in France, but one of the specialties is oral surgery. And the oral surgeons have traditionally had access to GA services. So patients referred for dental care to hospital services, to GA services, have traditionally met an oral surgeon.
And the oral
What happens
surgeon
when you meet an oral
typically,
surgeon is that you leave without your teeth.
exactly, extraction. Yes, yes. So,
So
I guess
getting
that was my,
conservative care, restorative care into hospital has now taken off, has now really taken off. But I think we're still in early days with that. So yeah, I wouldn't say it was a regular thing. It's something people have been fighting for and is now becoming more acceptable.
Yeah, I think
thank you. Thank you so much. What fabulous presentation. Absolutely fabulous. Thank you.
Echo thoughts that I think we're clean out of the time we had budgeted for this, but I just want to formally thank you, Denise, for taking this
You're very
time
welcome.
to come and meet us all. And I originally met Dr. Faulks through the IADH, and I think it's a huge, you know, I've always enjoyed her work. I've followed her work, as you will see later on in this presentation. We've even worked with her on the curriculum here in Canada. So Denise, thank you for championing special care dentistry here in Canada. And on behalf of the IADH board and all IADH members, I really want to thank you for coming out here and sharing your thoughts with us on this Saturday morning here in the west of Canada, but evening there in France. So thank you once again.
Thank you very much for the invitation and for all your questions. So I hope you have a good AG.
Thank you.
Denise, my personal thank you, and you have a great evening.
Thank you very much.
Thank you, Denise. Appreciate it.
Bye now.
Bye.
Okay, back to our meeting, and we are going to put up, I believe, our year in review slide. We had in the past, here's the top priorities that we had suggested for this year. Executive succession planning, check. Fill membership and education committee chairs, getting there. Do more to increase awareness of CSDH, check. Oral health curriculum development, we're on our way. Continue providing input to national dental plan. And yes, now they're asking us to come forward and sit down. So I think that you will see reflected in these priorities from this year what has been going on in our committees actually speaks for this. So I would like to pass this on right now to our chair of the Advocacy Committee, Joan Rush. So Joan, if you continue now with your report.
Thank you very much. As you probably could guess from the commentary, we are quite involved in advocacy and have been in this past year at a board level because so much of it has involved advocacy directly to the government. And so we've worked together as a board. It's been excellent. And I'd like to thank the members of the advocacy committee who initially sort of launched us towards that direction. Dr. Ruby Batani, who's now in Alberta, and Dr. Daniel Botner in Ontario, Shara Naibolita-Lamello, who's here in BC with me, Dr. Olaf Plotsky, who's done so much advocacy work this year, and our newest member, we're delighted to see Dr. Ian McConaughey join us, and he's already been very instrumental in some of the work we're doing. So if I could have the next slide, please. So we spent a lot of time, as I mentioned, advocating on the in respect of the Canadian Federal Dental Plan, and we still believe that these are the primary foci that we need to achieve and maintain. People need to overall health. We need to maintain that relationship between medical health and our oral healthcare system. We need to ensure as we go forward the data that she was talking about, that we search for that. We need to ensure that oral health care is evidence informed and tailored to meet patients' individual oral health care needs, patient based, I guess. And we need to, we believe, incorporate time-based remuneration. And I think her presentation, Dr. Faulks' presentation, had a very interesting slant on how we might approach that. We'll certainly have to talk about that. And that finally, that patients are able to access a full spectrum of necessary care. We have always, from CDSH perspective, focused on the need for increasing preventive dental care. We don't want to find that persons who live with disabilities are only seen when they've already developed serious problems. So we made a first submission earlier this year, and we made second letters. We've had numerous submissions separately to the Canadian Dental Task Force, and we will continue to create briefs for the federal policymakers, and for that matter, for the provincial ones. So speaking of provincial policymakers, approval of dental anesthesia as a specialty was a necessary step for us to argue to provinces that we had the ability to increase access to dental treatment in a cost-effective, efficient manner if there were more specialists in dental anesthesiology that were able to meet that need. So it took a lot of work all of last year. Olaf in particular was highly involved, but everybody was, in going to all the dental colleges across the country. And indeed, finally, the CDRAF members agreed to approve dental anesthesia. That happened in February. I am sad to report that so far, apart from Ontario, which had already approved it back in 2004, no other province has yet taken steps to individually put it into force in their individual provinces. So obviously more advocacy is required. So if any of you are keen to work with your provincial colleges, please step up. We could use your help, but we will be advocating for that back at the provinces again. The Canadian Oral Health Research Strategy was a nice step. We've argued since the formation that we need more data. There needs to be more research concerning the oral health of persons with disabilities. And Olaf was invited, I was invited to join the Canadian Institutes of Health Research for their first ever meeting to design a Canadian oral health research strategy. That was last March. The group working on it, all members of IMHA, that's the Institute for Musculoskeletal Health and Arthritis, have gone quite silent in working on it. So we don't know the status of their design, but we have been asked, however, to participate in a research symposium taking place in Halifax. Some of our members, like Shauna, are already involved in presenting at that symposium. So we're considering finalizing a separate presentation, and work on that is required right away. So as for enhanced oral health education, we're cognizant that no dentist can do what they don't know how to do, what they haven't been trained to do. And dental faculties across the country have not required, and neither has the Commission on Dental Accreditation of Canada required any training as part of mandatory part of undergraduate dental education. So we have been advocating for enhanced oral health education, both for all, not just for dentists, but for all oral health professionals. And we're getting some, I would say, interest, but I think the pushback is that it is hard, challenging, especially when the undergraduate curriculum is already so full. But nevertheless, we will not give up, and we continue that advocacy. So again, if you're interested in oral health education in any aspect of oral health professional work, please step up. We'd love to have you. So thank you very much. That's my, and I'm handing off. I'm sorry. I am passing off now to Carol with Special Olympics.
Carol,
Carol?
you're
Darn, sorry about that. Thank you, Joan. And I just wanted to first of all start off by saying how very thankful and honored I am to work with the people that you see up on the screen here. Dr. Tracy Doyle, Victoria Formosa, who's the new health director with Special Olympics Canada, Dr. Clive Friedman, who does not need any introduction, Jody Rancor, Joe Swimmer, and Dr. Ellen Wu. And this team is just incredible. We've met 5 times this year. And I think, you know, the other thing I would just like to highlight is this, we're a very inclusive society. And so our committee is made up of dental assistants, dental hygienists, dentists, and specialists. Next slide, please. So what's the committee all about? If this is the first AGM that you're joining, we have so many shared goals with Special Olympics Canada that we decided to enter into a memorandum of understanding with Special Olympics. And we work together and collaborate on many shared goals to make a difference. Now, over the course of the year, we've had 5 meetings, counting next week's meeting. So the commitment is not huge. We've worked on many things, and I'll just quickly share a few things. We've met with Special Olympics Canada on a number of occasions, and with different chapters or regions or provinces, as you might refer to them, to support our common goals. And so one of the chapters is Special Olympics Ontario, and they've been a leader in establishing a searchable database of health professionals. It's called the Partners in Health Program, and there are 19 dentists and hygienists on that list who have to do some qualifying CE and modules, and then are recognized and put on this list. Well, we would really like to, first of all, encourage any Ontario members on the call today to consider, you know, stepping up to the plate with this, because I think it's a great way for individuals with intellectual disabilities to find a dental home if they're searching. We are working with Special Olympics Canada to encourage other regions to use this model, and let's spread the wealth across Canada. Now, another goal is that we've been working with Special Olympics clinical directors, and we've been kind of networking with Special Olympics Canada to be able to directly communicate with them, build a database, and grow that network and collaborate with these individuals as well. And then another big project that our committee has undertaken in the past year is called the Self-Assessment Tool and Fellowship Project. So I'd like to advance the slide. Thank you. So I think what's most important to know about this tool is it's a draft tool, and it's multi-stream tool for all oral health professionals. So you could be an educator, a researcher, or a clinician, and use this tool. And it was initially a way to identify criteria, because one of the Special Olympics BC said they would like to know what criteria they should use to put providers on their list. And we're like, So we went all the way through the fellowship documents and then came back to arriving at a special assessment tool. And I really want to acknowledge the people who are working on this, Dr. Ellen Wu, Jody Rancor, and Clive Friedman, and they've done an incredible job, still in the draft stage. But what I've got here for you is just 4 stages, so you can kind of envision where we're going with this. So number 1 was, first of all, our vision. Really, we need more oral health professionals with knowledge and expertise to care for people living with disabilities. Hands down, we all know that. So an objective, number 1, was to develop a tool to assist our members and the general public oral health professionals, what were their strengths and what are their areas of focus? What do they need to collect in their toolkit to be able to really competently and confidently care for individuals living with disabilities? And number two, once we've got that, we really are interested in exploring the opportunity to launch a Canadian fellowship in special care to acknowledge and identify ready and willing oral health professionals. And then following that, we'd really like to advocate for a special care fee guide. So that would be a way to adequately remunerate and recognize those individuals. And as well, this whole process would flag individuals for individuals living with disabilities to locate. And finally, all of this is building up and complementing each other to then advocate for Canadian specialty and special care for all oral health professionals. So we looked at all the fellowships out there. These are the domains that were developed, and stay tuned for more information. If this is something that is really igniting a flame and speaking to your heart, I'm sure we would welcome you onto this project. We'd love to have you. The more brilliant minds, the better, because we all think a little differently and get to an amazing product. Next slide, please. And just finally, our objectives for 2024. You'll see the ball bouncing on the left is important. We've got the Canada Winter Games happening in Calgary in February. And so we will be working with Special Olympics Canada to lead the Special Smiles Oral Health Screening event there. We're hoping to develop some resources and definitely coordinate and support on site. So if that is interesting for you, we would love to have you as a volunteer. Please contact any of us, and they'll get it to me, and I'll send you the forms. It's an incredible experience that, honestly, hands down, will be one of your professional highlights, I'm sure. So we want to launch that self-assessment tool this year and support our next steps in developing a fellowship. We're working again to identify and mentor clinical directors, and we really want to expand the Partners in Health program nationally. So we've got lots on our plate, but all exciting, doable things. I'm going to pass it on to Sharat next there.
Thank you, Carol, and it is a pleasure to come before everyone to present the work that we've been doing at the Research and Education Committee. So we are a committee that is in transition. So while I chair the scientific, we've had a transitional educational chair in Cecilia, with Dr. Friedman, Dr. Babe, Jody, Cynthia. It's an amazing group of people. If you could just move to the next slide, please. So basically, the role of our committee is twofold. And in the past years, as many of you who are older members will know, we did run a lot of webinars. We did have a target of running at least 3 webinars a year. And moving forward in 2024, this committee hopes to get back to that. So this is a shout out here to everybody on this call. If you're interested in hosting a webinar, if you do have topics that you feel would be good for webinars, please send them to us and we'll be happy to put them together. It is a part of our committee that wasn't very active in 2023. However, where we have been active has been in the scientific committee. As Joan mentioned, the advocacy committee has been going to conferences, going to conventions, and putting forward ideas, and there has been a lot of interest in what data is currently available on special care dentistry in Canada. And the answer to that has pretty much been there is not a lot available. So what the research committee has looked at is basically twofold. One is taking education to be the benchmark of what we do. The educators on the committee, that was Cecilia and me, along with our keynote speaker for today, Denise Faulks, we got together. And what we did was we looked at the undergraduate curriculum as it exists in Canada through the ACFT competencies. And we mapped this with what the IADH calls the undergraduate curriculum in special care dentistry. And one of the interesting findings that I really like to share with everyone here is that we found that on every single domain that was listed, both on the IADH curriculum as well as the ACFD competencies, there was 100% agreement. So basically what we've been able to show has been that we can teach special care dentistry within the current framework of the ACFD in Canada, which was huge. And this paper has now been circulated to the deans of all the dental schools in Canada. Again, big thanks to Dr. Olaf Klatsky for his tireless advocacy in following up with those deans and making sure this paper has been circulated. Another project which a lot of our members, not directly the education committee, but also the wider CSDH community, especially the executive, has been involved with, is in an upcoming series of articles in oral health on how to manage individuals with special care dentistry. And we hope to see the first of these articles in print in early 2024. Similarly, if anyone here would like to come up with articles, you have interesting cases, interesting approaches that you would like to share with us, we call on all of you to send it forward. And we look forward to working with you and for you in 2024. So with that, I hand over my mic. Thank you.
Thanks, Sharat. So on that list of priorities for 2023, I think the third one down was about increasing awareness of CSDH, and that has been largely the focus of the communications committee. And I want to acknowledge the two members that I've had throughout the year. Dr. Vlad Podskalny was with me earlier in the year, and Sharon Martins has recently joined the committee and is doing a lot of, actually all of our social media work on Facebook and on Instagram. So I'm grateful to both of them for their ideas and for the initiative that they've taken. Some of the things that we've done throughout the year, it was great to be able to get back to in-person meetings, and we had the exceptional opportunity to attend the Pacific Dental Conference in March of 2023. They so graciously gave us a booth for free and lots of free stuff. So we were able to go there with a number of our members, and we talked to lots of different people who came by the booth, some of whom joined the society afterwards, some of whom shared their own personal stories. So we are planning to go back to Vancouver in March of 2024 for the same type of opportunity. And so if anybody is planning to be in Vancouver for the conference next March, if you want to, participate with us at the booth, that would be wonderful. If you are planning to attend a conference in your own province, and if you could arrange for us to have a free booth there and want to man it yourself or with some other individuals, just again, kind of let us know what those opportunities are. We can provide materials and support for that, and especially when there are local people that are going to be in attendance, that would be a wonderful opportunity to pursue. One of the other things that we did this year is we introduced a new logo for the CSDH, which we think has far more meaning than the one that we previously had. If some of you are new to CSDH and don't know the story behind kind of the meaning and the symbolism of the new logo, if you scroll down on the front page of the website towards the very bottom, it does show you what all of that means. And speaking of the website, we also revamped our website this year, and really think that the changes that we've made, even though the content is largely the same, that the website itself is more reflective of who we are and the people that we represent. It's more visually appealing, it's certainly more functional. And we think that by, when people are browsing through the website, we certainly hope that they will linger longer and learn more about us. In fact, just a trivial point, but even the little contact us button, since we launched maybe a month and a half ago, we've had several people actually contact us through that contact us button. And some of them had questions about finding care in their own area, and we've been able to respond to them. So that part is working and helping to increase awareness. The other thing, and all of this, I think we've shared with you as it happens. And so maybe some of this is not particularly new, but earlier in the year, actually there was an article on the CBC about special care dentistry. I know Impact Dental in Mississauga was featured in that. Dr. Paul Romanson was featured in that. And so just being able to get this national exposure through the CBC has been incredible. And again, since then, we've had 2 additional inquiries from CBC. And so the opportunities there are certainly for us to get even more recognition through that method. Just checking my notes to see if there's anything else that I wanted to talk about. So our objectives for 2024, it was so great to hear Dr. Faulks talk about this, is sharing personal stories from people living with disabilities. That is something that we want to start to do in 2024. And to her point, like, it's so important to get those stories in front of these government officials. I think that can have a huge impact, and not just with the government officials, but we'll, share them on our website. However else we can do that. Again, it's one of those things, we're not exactly sure how we're going to do that, but that hasn't stopped us before. So that is a number 1 priority for us. And then also just, again, increasing our social media presence, and not only just, pushing stuff out there, but also engaging people on social media with us. So those are our objectives for 2024. And like everybody else, I will put the offer out there. You have ideas. If you want to get involved with this, we will always accept new people who would like to be more involved on the communications committee. And with that, I am passing it over to Shauna. Oh, no, I'm not. I'm passing it over to Dr. Plotska and to Lara Timler.
Thank you very much. One of the things at the outset that we came to the conclusion that if there's going to be any change at all in the profession, it has to start at the ground level. And that would be in the undergraduate level. And when we say student chapters, we mean all oral healthcare providers, being dentists, hygienists, dental therapists, dental assistants. The mission and mandate you can see here, and you can certainly see it on the website when you visit that. Next slide, please. Yeah, one of the things that I'm going to point out, this was absolutely fabulous, and I do have to give a shout out to Dalhousie. They've taken a huge leap of faith in putting themselves out there as one of the major student chapters. I'm going to have Shauna just comment on that before we go to the next slide.
Great. So this was an initiative that was led by our student chapter president last year, Ashley Fletcher. And it's a great open access free tool for you to use in your practice. And the goal is to provide an orientation or an overview of what to expect when you visit the dental practice. Anecdotally, we've heard lots of great feedback about how that it has helped to provide some comfort and lessen anxiety for people who are visiting the dental practice. And so you can find this on our website and on our Facebook page as well.
Thank you. We've been very fortunate. We've had Lara Timler, as I reported earlier, join us as a director, but she's also taken the huge step of becoming the chair of the Student Representation Committee. And Dr. Drew Smith, who just indicated that he had to leave the meeting on a personal matter, he has also graciously joined the Student Representation Committee. He's a strong advocate for students. He has a master's in bioethics, which speaks strongly towards professionalism, which is a basis for dental education and all oral healthcare providers including, as I said previously, dental hygiene, dental therapy, and dental assisting. And right, so the Student Representation Committee has gone through a bit of a change in the years. As I indicated, Lara Timler joined us, Drew has joined us. We made an effort to reach out to all of the oral healthcare provider facilities to try and recommend a full-time faculty champion. This individual will help facilitate continuity because we know as students graduate, they're going to move on, they have new priorities. Hopefully they'll continue with the organization. And as the new students come from first, second, third, fourth, or in whatever year in their respective programs, to maintain the continuity. What I do need to point out is the student chapters are all autonomous. They make all their own decisions. The challenge will be to develop a term of reference that can be used all across Canada for all of these oral healthcare provider student chapters. We did start by connecting all of the current chapters with the current faculty champions and with the chair of the committee. All right, Lara, over to you.
Thank you, Olaf. So I very recently joined the CSDH Board of Directors, as Olaf mentioned, and I'm really looking forward to working with faculty members and students across Canada to advance the mission of the CSDH. So we really believe that building a strong network of student advocates is a really important first step in that mission. So to this end, I'll be working with or facilitating the development of student chapters in colleges and universities across Canada with the help of Dr. Drew Smith. And as Olaf mentioned, we're currently seeking faculty champions in all oral health education programs. So that's including dental assisting, dental hygiene, dental therapy, as well as dentistry. So current members are encouraged to put their names forward as faculty champions, and students and student members who are current members who are interested in starting a student chapter are also encouraged to get in touch with me via email so we can explore some exciting opportunities to grow both student and faculty involvement across Canada. So next up, Shauna is going to provide the Treasurer's Report.
Thank you, Lara. As you can see from our small graph here, that we have had a steady increase in revenue over the past few years. And in part, this is due to an increase in membership and an increase in sponsorships. I've also highlighted here some major expenses that we've incurred over the past year, which is defined by $500 or more. And so one is being the portion of your membership dues that go to the International Association. But in fact, that's not a bad expense because it's directly tied to the membership fees that you are paying and a number of members that we have. We also have IT domains and subscriptions, accounting fees, website and design, and the expenses that we've incurred for attending the Pacific Dental Conference. It's important to note that the website design and the conference expenses were from a sponsorship and not from membership fees. And we luckily have someone who's able to provide us with in-kind support to do our taxes for next year. So you will not be seeing this fee moving forward. If interested in more information about our finances, you'll find that in our annual report coming soon. So I will pass over to Paul.
Thank you, Shauna. I have our 2024 priorities, and these are mine. So don't blame anybody else. These are mine. And I do look for input throughout the year on priorities and how we move and shift focus. So I'm just going to read through here. Continue advocacy regarding the National Dental Plan. Well, that is ongoing, and we are really on top of this as best we can. And we are being invited to meetings by the government, so it shows we're doing something right. Now, expand our CSDH collaboration with other oral healthcare associations and groups focused on people living with disabilities. And that is something that our speaker, Dr. Denise Faulks, actually spoke to as well. She said you have to get out to these other organizations and make a presence and gain the strength in numbers. and increase the focus on education. And I think the word here is awareness. We still have to make education awareness a big priority. So influence oral healthcare curriculum development through student chapters and faculty champions. And thank you, Lara, for coming in on this, and Drew and everybody else is helping out. And expand the portfolio of educational offerings and make them readily accessible. So I'm wanting CSDH to be a go-to organization for education, to have our website, populated with meaningful educational materials, and to be continuing, as Sharat said, to provide webinars and lectures as we've been doing. There's also the fellowship and self-assessment process. This is so important that everybody review this, get on the website, and get involved with this self-assessment process and the fellowship. And I've been getting through this myself. It's very educational, very rewarding. And as other people have been saying, I want to provide more opportunities for member engagement. The strength from membership is so vital, and we have so many talented people in our membership, and as well, we want to advance our numbers. So that's 2024, and I invite your comments, and we will carry on with this to the best of our abilities. Now, we have some other things we have to move on to, and one is the bylaw change for line officers. And the bylaw change, in a word, is to make the offices be more fluid and give a chance for people to get on the line and serve on the CSDH board with a little bit more experience going towards the presidency. So I know everybody has had the information on this. I'd like someone to move this motion to add the president-elect position to the board of directors, increasing our number of line officers from 3 to 4. Someone just move this, please. I can't see. Thank you, Steve. And Carol is going to second. And if we have the poll to vote, please.
Question again, is the poll visible on your screens?
It is
No.
not.
No, sorry, it's
We may
glitched.
have to do show of hands again.
Show of hands again is just fine. Please, everybody, put up your hand for a vote on this. Thank you very much. It appears that we have our majority, and we'll move on. Now for the bylaw change number 2, and this is to add membership as a standing committee of CSDH. And we can just see that the membership committee has been moving on in great strides, and it is a vital part. So once again, adding this to the bylaws is the correct thing to do to solidify our organization. So I'd ask for someone to move.
I
this.
move.
Thank you very much. And someone to second.
I can second.
Thank you very much, Shona. Okay, and if we do not have the poll available, then please a show of hands for voting on this. Thank you, everybody. I think that pretty much covers it. And Chantal, I finally see you there. Thank you. Now we have the job of ratifying the board. The list of board members for this year has gone out. And so the slate now to serve for 2024 board, Dr. Ola Plasky, myself, Sharat Pani, Joan Rush, Carol Yakuchuk, Shona Hatchie, Lara Timler, Steve Lipinski, Liz Morch, and Lindsay James. Now I'd like a motion to move that we ratify this slate of directors. Right. Anybody see a hand there for this motion? Olaf, and a seconder.
Second.
Thank you, Steve. And if we still don't have the poll ready, then I believe that a show of hands is in order. So everybody that wishes to vote for and ratify this, thank you very much. Then we'll move on.
This one might be more difficult.
No, it's not going to be more difficult because I'm just going to smooth this over. We have the suggestion for interest in a different date and time of the AGM. We are all recognizing that our time is important. November is getting to be a month of crushing meetings and other things coming up. So I do ask everybody in membership to, and we may just put out an email for this as well for those that not in attendance, and just ask if, you know, October is better or January or whatever, or do we keep on with the same? So we will work on that, and we will not make a decision right here and now, because it's not going to be impossible to engage people and have discussion. So if we just leave that one for one of our next bits of business for after the AGM. Now I'd like to hand off to Barbara, please, to continue with the membership renewal.
Yeah, all right. So every year, we start our membership renewal campaign in October, and anybody who renews their membership before the annual general meeting gets a chance to win their membership for free. So I am going to pull a name out of my little bucket here. These are all of the people who renewed. And the person who is going to receive their membership for free is Thomas Oper. I don't know if you can read that. So we will make sure that Thomas is informed of that. So, all right, then this is for, well, aside from, you know, Denise's presentation and all the committee presentations, this for me is the highlight of the annual general meeting. We're going to play trivia. So if you've got your paper handy, and this will take like 8 minutes tops. So the subject this year is famous smiles. Who's behind the smile? And there'll be a number of pictures are going to show up. There's 2 pages of pictures. The numbers go like down, so make sure you're paying attention to the direction of the numbers. And here's your first set of pictures. Are we ready to switch pages? I'm gonna change. We can go back if you need me to. So are people done? Do you need more time? I'll wait for another few seconds. I see people still look like they're answering. All right.
Almost done.
Almost done. Okay, thank you.
Famous smiles. They're doing.
You ready for the answers? Sure. All right, here you go. So number 1 was Julie Roberts, 2 was Freddie Mercury, 3 was Mr. Bean, 4 Tom Cruise, 5 might have been a harder one, Lauren Hutton, 6 was Kate Middleton, 7 was Princess Diana, 8 was Jack Nicholson from The Shining, 9 Alfred E. Newman, 10 might have been tricky, that was Rudy Giuliani's mugshot, 11 Jack Sparrow, 12 was the Cheshire Cat, 13 was Jim Carrey, 14 Rachel McAdams, and 15 was Matthew McConaughey. Anybody get them all right? Anybody get 14 out of 15? You can unmute yourself and shout out bingo if you got them all. All right, that's it.
Perfect.
Okay. The other thing that I just wanted to do, we wanted to give recognition to all of the new members that we got within the last year. So I did this from like November 1st to October 31st. We have had some new members join even since October 31st. We'll acknowledge them next year. So I think we had 36 new members join in the last year. And then I just wanted to point out on here, the 3 people that are highlighted in blue are people who had been students and who converted to Class A members. So we really appreciate the fact that they did that. We would really like more of our students to convert to Class A once they graduate as well. So we need more focus on that. And then we had 26, I think, new student members join in the past year as well. So again, we're just so grateful that, you know, people are joining the society, and hopefully we will continue to expand our numbers. And then this one, Paul, I think is over to you if you want to talk about this one.
Well, yes, I would personally like to say a big thank you, a heartfelt thank you to all of our committees and committee members, the people that have been doing the ongoing work. And I'm also liking everybody to know that our committee structure has been solidifying over the last few months. And I'm really looking forward to this upcoming year and working with everybody on the committees, because I will be serving as a member, a non-voting member, of course, as president. And so, yes, thank you, everybody. Looking forward to this year. Okay. And allow me to continue. These are my thank yous. First of all, board members, past and new, thank you very much for continuing. I'm getting some feedback. I don't know if somebody's got something open. They should be muting. I'd like to give a big shout out to our sponsor, Patterson Dental, who invested in helping us with our website, our new website, and it was so well done. And Barbara ran a very personal thank you for your organizational skills, for everything you do to keep us on track, for putting most of this AGM together. Our delightful and amazing speaker, Dr. Denise Faulks, thank you so much. And to you, the members that give the CSDH mission and strategic plan purpose and validity. You are appreciated, and your involvement and expertise on committees and with the future board positions is eagerly anticipated. So I'm very much looking forward to serving you as CSDH president this year. I thank you for your confidence when you ratified my term along with the rest of the board. We have a fantastic board this year, and with the ongoing help of membership, I know we will continue to be an active and productive force in continuing to advance a level playing field for the oral health care of our citizens in Canada who are living with disabilities. Overall, I'm really looking forward to working with all. Now, I would like to leave you with a thought that you can take to heart. These are the words of Jen Irwin, who is a professor at the University of Western Ontario, and it is from her brilliant seminar on kindness. Kindness is a quality of being genuine, well-intentioned, and often involves courage. Thank you, everyone. Now, we will remain on air for a few moments yet for conversation right after we adjourn. So our last official thing is to call for an adjournment. Do I have a mover for adjournment before we stay together? Joan, and a seconder?
I can second.
Thank you, Lara. And show of hands? Great. So we are so adjourned, and please stay on for an open 15 or so minutes together. Thank you.